So if anyone's joining, sorry, we're just waiting for people to come in. I can't see the side of my screen to see who's all there. So we're going to wait another minute or so, then we'll get going. Okie dokie, I think that's just after 1 o'clock, so I think we'll get going. So thanks everyone for coming. I'm Alan McFarlane. I'm a consultant anaesthetist up in Glasgow, and I'm leading NAP8. Thank you first and foremost all for volunteering to be local coordinators. The NAPs certainly cannot run without all your input, so we're really grateful that you're all helping out with NAP8. The real idea of today is really just to give you an introduction to the project, to show you where we're at in terms of the timeline. There's been a lot of work going on behind the scenes, and then to listen to your ideas and input before we get going in the next couple of months. There's still time to listen to you and see if there's anything else you think we need to be doing. So without further ado, we'll get going. Just to say, there's a chat function at the side of the screen. We've got our fellows with us. Eric is working in London, Eric McMower. Sophia Roses is up in the west of Scotland as well, and Yin Lim is down in Cardiff. So all three of the fellows are here, and there might be some other of the steering group lurking about in the background as well. So if you put your questions in the chat, then I can't see them at the minute, just the way my screen is working, but they'll answer some of them, and if they can, and we'll go through any questions at the end as well, of course. So, as I say, NAP8 is all about the major complications of regional anaesthesia and other perioperative nerve injuries. And what we'll go through really today is why that's going to be the topic. We'll give you an update as to where we're at in terms of the methodology and progress. Talk a little bit about what's new with this NAP, some of the potential difficulties that we think might be an issue with this NAP, and then really spend the last little while talking about your role as local coordinators and what we're hoping you can help us with. So in terms of why NAP8, then this is the proposal you might have seen, or the call for proposals that the college put out. This was back in summer of 2023. And all the NAPs are really based upon these principles that it has to be important to patients, it has to be important to anaesthetists, has to be incompletely studied in incidence or nature, and not suitable for study by any other methodology. And so in terms of regional anaesthesia, as you all know, it's certainly undergoing a renaissance the last sort of 10, 20 years. It's now got its own place in the 2021 curriculum. We've got data from residents done with the RAFT group that more and more residents want to incorporate regional anaesthesia into their consultant job plan. But like all anaesthetic forms of anaesthesia, there's complications, and there's certainly complications with regional as well. But interestingly, when you look at litigation, regional anaesthesia comes out at top of the list, and more importantly, perhaps, the number of cases due to peripheral nerve blocks has doubled over the past 10 years. And so if you're a patient coming for your operation and you're trying to make a choice between having a regional block or general anaesthesia or combining the two, then clearly we need to give patients figures and give them accurate data so they can make that decision. And we've got data already from NAP3, but that was published in 2009. All the work was done for that in 2007, so that's been almost 20 years since NAP3, which was looking at just central neuraxial blocks, was done. So times have changed. We know of in all the subsequent NAPs that patients are older, they're frailer, their BMI is increased, and they've got more comorbidities. And we've clearly got a whole selection of new anticoagulant agents that didn't exist back in NAP3. So the risk profile potentially for central neuraxial block has changed. But we don't have such good data for peripheral nerve blocks. And that's one of the things that we were really keen to study in this NAP as well, because that's, as I say, the data's not so good. This is probably the best data we've got so far. This is from Dave Johnson in Belfast and Canadians and others who published a big sort of narrative review over 92 studies. That was published in 2023, and the figure they came up with was about 1 in 3,000 for permanent nerve injury. But if you read the literature, as I'm sure a lot of you do, you'll know that a lot of the studies don't follow patients up long enough to know if that nerve injury is definitely permanent or not. And there's also a lot of the time not enough investigation to try and figure out if that injury was definitely due to the nerve block or not. And as I say, there were 92 studies, they had 107,000 patients when you add them all together. If you look at NAP7, there were 315,000 peripheral nerve blocks alone in NAP7. So this number we've got is already almost 3 times as much. We've spoken to needle companies and we know that in that same time period, they've sold between 8 and 900,000 needles. So there's a gap somewhere in the middle between what was reported in NAP and what's actually happening in real life. So it might well be that this figure's substantially higher. But either way, if we can pull NAP8 off, it's going to be the biggest study of peripheral nerve blocks in the world to date. But if you're a patient coming for your operation and you end up with a nerve injury, arguably it doesn't matter whether that nerve injury has come from a regional anaesthesia block needle or a spinal or an epidural needle, or because it's due to positioning or some other injury that's happened during the general anaesthetic. And the best data we've got for that so far from the college leaflets suggests that that happens in about 1 in 10,000 patients. And there's lots more information here about ulnar nerve and perineal nerve palsies and brachial plexus injuries that David Hewson and John Harbin have written about in BGA Education. And as I say, it's got to be important to patients, it's got to be important to anaesthetists. And if you talk to patients, then it's quite sobering when you listen to their story about the risk of permanence, the risk of disability, and that worry during the early phase, because fortunately a lot of these injuries do disappear. But as I say, we've got patients who've been wheelchair bound or chronic pain because of nerve injuries after peripheral nerve blocks or injury during general anaesthesia as well. So just a wee interlude, that's just pictures from Arran, one of my favourite places in Scotland. That's just the island on the boat home. And the left's Glen Rosa. It's a lovely walk up the glen. You can go swimming in the rivers if you fancy, even though it's a wee bit cold usually. So where are we at so far? This is really the slide that we'll probably have up on all your walls. This is the inclusion criteria. There'll be posters of these all prepared for you all in due course. And what we're looking for is any procedure under the care of an anaesthetist, whether it's a general anaesthetic, a regional anaesthesia, sedation, or monitored anaesthesia care. And we're looking for patients who've suffered moderate, major, or severe harm as a result of either regional anaesthesia, so peripheral nerve blocks, central neuraxial blocks, or surgical local infiltration, because you'll remember the tragic cases of, there's one in the coroner's report recently, a patient who got local anaesthetic infiltration for hip arthroplasty and sadly died, and harm due to not regional anaesthesia, so any perioperative nerve injury that's not directly related to the surgical procedure. So we're looking for things to do with compression or positioning or tourniquet injuries or very rare spinal cord injuries, which, as I say, are not due to direct surgical damage. And we'll be looking at cases in children, looking at blocks in intensive care, and all the pain blocks as well. If the anaesthetists do a block in the emergency department, then that's our responsibility. We're not looking for blocks done by emergency physicians in the emergency department. That's a whole separate project. And in fact, the Royal College of Emergency Medicine are going to run a little mini NAP to do that. But it's just cases where anaesthetists are involved. That's what we're looking for. This is the timeline, the sort of Gantt chart of all the work that we're doing. I started in October 2024, so we've been going for over a year already. It's certainly not just me, as I said, we've already got the fellows who've been working since last August, and there's a big team behind the scenes at the college. Laura is the project manager. She's been off, unfortunately, just for the last sort of 6 weeks or so. So I just apologise if there's been any sort of delay in getting back. We've got a new team or a new person, Dom's just coming in as of last week, and there's other people who've been helping out answering the mailbox and getting on with things behind the scenes as well. So we are working to get things replied to as soon as possible if you have been messaging us. What we've been doing up until now is we've been building the whole protocol up. So we've, as you I'm sure are aware if you've been involved with NAPs before, there's the baseline survey, the activity survey, and the registry phase, which we'll be talking about in a minute. So that's all in a big document. That jigsaw's pretty much done, but not quite. Before the steering group came together, there was a lot of help from these people here. So Rosie Hogg in Belfast, Kareem El-Bogdadli in London, Nuala Lucas, the OA president, David Hewson, who's now the RE UK research lead, and Rachel Kearns, who's up in Glasgow, who was the previous RUK research lead. So they were helping with that. This is where we're at now, so November 2025. The stakeholders all joined us in January, so we've got all the usual people you'd expect. We've got RUK, ESRA, the OAA, the APGBI, the Association, Faculty of Pain Medicine, Faculty of Intensive Care Medicine. We've got surgeons involved, neurologists, neurosurgeons, neurophysiologists, peripheral nerve surgeons, residents are from the RAFT network, and of course, patients. Ireland are going to be joining us. So Ireland took part in NAP5. There's a big regional anaesthesia network in Ireland. So Brian O'Donnell's leading that, along with Aoife Driscoll, who's the resident who's looking after NAP8 in Ireland as well. So that will boost our numbers by about 15%, which will make the work even stronger. You'll probably know that the independent sector traditionally and understandably haven't been hugely involved in the NAPs, but we've been working with IHPN and the Private Healthcare Information Network, PHIN, and they've been fantastic so far, and we've been engaging with all the leaders of the major independent sector chains who've agreed to take part. So we are hoping to get better engagement this time round from the independent sector, because there's a huge amount of blocks probably done in orthopaedics in the independent sector. So that's a big part of NAP8. Just to let you know briefly that it costs hundreds of thousands of pounds to run a NAP. There's a big team behind the scenes at the college, and part of my job is to get funding. So just to sort of thank all the organisations up in the top right who've all contributed money towards the NAP8. The college fund the vast majority of it, but we have been supported by these organisations up in the top right. What we're going through at the minute is the approval process. NAPs don't get classified as research. They don't go through research and ethics committees, but we do have to still go through a whole process to make sure that we don't get into trouble and the college don't get into trouble. So essentially what we are doing after discussion with lots of people is we're getting a Caldecott approval from every hospital trust in Scotland, England and Wales. There's literally hundreds of applications have gone out to each of these centres. We're doing all that. I know if you've signed up, you'll have given us your local Caldecott Guardian, so thank you for doing that. So we've been approaching them all directly. And if there's any issues, we might have to get back in touch with you, but that's progressing. And we're about a third of the way there at the minute. Northern Ireland have a separate information governance panel, so it's been through them and we're just waiting for their decision. And in Ireland, it goes through the National Centre for Clinical Audit, and it's all approved in Ireland and good to go. Time is certainly pressing on because as I'll say to you later on, we're hoping to get going with the main case registry in March. But we're definitely making progress. So fingers crossed that'll all be in place before we get going. I've already introduced you to our fellows. They were appointed in August. They've been working away and they're working on all that stuff that's flashing away, which we'll talk about in a minute. And that's Aoife, as I say, who's running the show in Ireland along with Brian O'Donnell. So the sort of next 10, 15 minutes are really just to sort of go through the whole process in terms of what the NAP will be, how it's going to work, and how your role as local coordinator is going to be in terms of helping us. So it's all going to be done on, or not all, but the baseline surveys and the activity survey will be done on something called Smart Survey. It's very similar to SurveyMonkey, but this is a UK programme, so it's better from an approvals and a governance point of view. So the baseline surveys are the first part, and there's two of them. As you know, there's one that's going to go to each of you as a local coordinator, and there's one that will go to every single anaesthetist in the UK. And we're actually due to launch them next week. We've not been really having a big fanfare about that because that's not really the main component of the NAPs. The main component is the big 1 year registry phase, but I'll talk to you a bit more about the baseline surveys shortly. So we'll have them. They'll be open for a couple of months. Then we'll move on to the registry phase, as I say, probably March, which we'll talk about in a minute. The baseline surveys, they're going to really look at aspects of regional anaesthesia practice. So there's questions about rib fractures, intrathecal opioid, barriers to regional anaesthesia, consent, provision of information to patients, follow-up of patients. It'll look at individuals' experience of complications and service delivery and provision in terms of regional anaesthesia leads and acute pain leads, and a few questions about training as well. So that has built up quite a big picture about regional anaesthesia practice in the UK. The activity survey will probably run in June, so that runs in the middle of the case registry. We've been chatting to statisticians, and it looks like we'll probably run that for 7 days. So you might remember some of the initial NAPs were 2 weeks. NAP7 was 4 days. We're going for 7 days, it looks like, for NAP8. And it'll probably just run from a Monday to a Monday. We're still deciding whether to do two separate, sort of randomize that over a 2 week period. But it looks like we'll probably just run a full week from Monday to Monday to make it nice and simple. And we use that, as you know, to multiply that up to get our denominator data, and that gives us an estimate of the number of cases in 1 year. This one will be a little bit more in-depth than NAP7. It still has to be nice and quick, but you'll maybe remember from NAP7, if you were ticking all your boxes when you were filling out all your cases, there was a list of anaesthetic techniques, as you can see here. But if you look and think about it, for example, for labour and people coming for an emergency caesarean section, if you do come for an emergency caesarean section, I can't say that word, if you come for an emergency section in the middle of the night, or a caesarean birth, I suppose, if you come for that in the middle of the night and you've already got an epidural that's already in place, then we need to be careful that that doesn't get double counted. So we've got boxes now for epidural top-ups or spinal catheter top-ups, whatever might be in place, to make sure that we collect all the data a bit more accurately than has been done in previous NAPs. And if you do come and you have a regional technique of any sort, not just for obstetrics, then there'll be further questions about your regional technique as well. Again, just a limited set of questions. We then got that 1 year case registry, and that's hoping to start in March 2026. That will last 1 year. Every case that comes in will get reviewed by a multidisciplinary team to try and work out if the case was definitely due to regional anaesthesia or not. And there'll be a 6-month lag time as well, so that if you present on day 365 with a peripheral nerve injury, we need to then follow patients up for 6 months to see if that resolves or not. And if it's still there at 6 months, then we'll classify it as permanent and it'll get kept in the NAP7 case, the NAP8 even case registry. And then you remember we use all the figures from the denominator from the activity survey, all the figures from the case registry, and that will give us our incidence of all these rare complications. So in terms of what's new with this NAP, this will be the first NAP that's been a re-audit. There's also been criticism of previous NAPs with too many recommendations. So we're going to try and do that a little bit more scientifically for this one and potentially grading them, or at least doing a Delphi process. We'll figure that out later on. And there's other countries that are involved as well, but we've got too much to sort at our end first before we start franchising out to Belgium and other countries. But that's a possibility for later on at the end. In terms of some of the difficulties, you can see all the things that are green here, some of the major complications of regional. These are all more than likely to happen in the hospital when there's an anaesthetist present, as you all know. So things like cardiovascular collapse, wrong root errors, wrong-sided blocks, local anaesthetic toxicity, and pneumothorax. I think the numbers for these are going to be pretty accurate because you'll all be there, you'll be able to get it reported. The ones, as I'm sure you've already figured out, that are going to be tricky are the permanent neurological injuries, because a lot of our patients are being discharged with peripheral nerve blocks and we'd want them to be numb for 24 hours. And I don't know about you, but we probably don't follow our patients up as well as we could locally in Glasgow. So there's always a risk of potentially missing these cases. And that'll be part of your role as local coordinator to help promote the project, which we'll talk about in a minute or two. I do think we will get the major cases because that's all we're looking for. We're not looking for someone who's numb for 2 weeks after the operation. We're looking for the patients with a major nerve injury that's still there 6 months down the line. And those ones, in my experience, do tend to get fed back to us because the surgeons are often looking for someone else, I think, to blame. So they often come back to us and say it's due to the block. So part of the project will really be trying to promote NAP8 among surgeons, physios, pain teams, neurologists, or potentially even medical legal teams, anywhere where these patients might present months down the line where we might not see them first off. So really now just to chat through things for you as local coordinators and how we sort of hopefully can help you out and how you can help us. And as I say, thank you again, just because it's a huge amount of work to do this project and we can't do it without your involvement. So what we'll talk about is just the process of local leads, the baseline surveys, the activity surveys specifically, and the registry phase and all the different components and how you might be involved. So just to go back to local leads, we haven't got someone yet for every hospital. As I've mentioned, Laura's been off, so the website, we're still working and just catching up with updating some things. But if you could perhaps, first of all, go to the website, you'll be able to find NAP8 on the Royal College website and click on your trust. This is just a random one I've picked here, so you can see at Bart's Health NHS Trust at Mile End Hospital that says to be confirmed. So that's either because we've not had a chance to update it on the website, or it's maybe because there isn't actually anyone there, or it might be because that's already linked. For example, I'm just completely making this up, but it might be linked to the Royal London Hospital. For example, in the Glasgow Health Board, there's a couple of hospitals which are listed, but they're actually linked to the main hospital, so it's the same local coordinator. So those of you who are here, if you could click on the website and just double check uh, if you know someone at that hospital, if you can get them signed up, or if they're actually linked to your main hospital, let us know so that we can tidy up these lists. And if you want to have a wee flick around, so for example, if you're on the Barts one, but maybe flick through one or two next door to see if anyone, if just in the off chance, which Barnsley's nowhere near Barts, but if you happen to know someone up there, give them a ping to see if they can sign up to be a local coordinator. So if you could do that, that would be fantastic. You should have all had emails by now about the associate local coordinator scheme. This is our first. We're going to try this out. Similar to we've got associate PIs and the residents and locally employed doctors and specialty doctors have been fantastic, helping out with many of the national projects as associate PIs. So we're going to try and do the same for the NAPs moving forward. And so there's going to be an associate local coordinator or coordinators for each hospital. We're going to leave that up to you. We can't get involved in appointing, local coordinators for 450 hospitals. But what we've done to try and help is we've got a person spec doc, and we've got a scoring system that's based on sort of job application scoring systems, and it's designed. If you've read the document, for stage 2 and stage 3 residents are equivalent if you're a specialty doctor or locally employed doctor. And what I would suggest is probably you decide on how many you think you need for your department. So in my hospital, for example, we've got 3 local coordinators because we've got a day case separate site hospital. So and our main hospital is pretty big, so we've got 3. So we'll probably have at least 3 associate local coordinators. We can't have like 20 on each site, but I would sort of think maybe match up the number that you've got for local coordinators and then appoint the same number of associate local coordinators. But ultimately, it's up to you. There's no magic number, no restrictions. Send it all out. We'll be sending out this document to the college tutors within the next couple of days. We wanted to wait just till the webinar was over today, so that's going to go to all the college tutors. It will go out via Raft as well. So you might get a fair bit of interest from residents. I think a lot of them already have heard about it on the grapevine. Then if you can get them to fill out your application form, score it, and then appoint based on that. And if you let us know, then we will keep a list of all the associate local coordinators. So that's that phase. The baseline surveys, as I've said, are actually going to come out next week. These just hang about for 3 months or 4 months. There's no magic end date. There'll be the individual survey, and that's going to come out to you for distribution, and there's the local coordinator survey that you have to fill out. So the local coordinator one I'll talk about first. So there's got to be one of them done per hospital site. There's going to be a fair number of questions about adults, questions about paediatrics, questions about obstetrics. So clearly it depends what you've got on site. There might be, well, not might, there are some questions about protocols. So it might be worth just going and having a look and gathering all the sort of relevant protocols. We've listed them in the introduction. It's useful maybe to get them and have a look before you start. If you start doing it, you can save it and then go away and have a look and come back to it. So that's not a problem to do it in bits. And you might want to go and speak to your obstetric lead as well to help you fill out the relevant section for that, because there's a separate section on obstetrics. So that will come out to you, as I say, next week. And then the other thing that will come out is there'll be a link sent to every single hospital for the individual surveys. There'll be a different link. So poor Sophia, who's been in charge of the baseline surveys, has been building up sort of 400 or so links, and that's really just designed to try and stop it getting spammed. There's some minor issues with bots in NAP7 and times have changed, so I suspect it could be worse in NAP8. So there's an individual link for each hospital. That will come to you as local coordinator, and then if you forward that to your department, and please just keep it within the department, don't publicise it on the internet or anywhere else, just keep it to your department, and that will be sitting there for all the individuals to fill out. It'll be your job, I suppose, ideally to try and gently persuade everyone to try and fill it out. One of the ideas we had was to, if you're having CPD or M&M, just to sit people down for 10, 15 minutes and ask them to fill it out during that session. There'll be certificates. When you get to the end, you'll have to click on a button, and that will take you to a link that I'm afraid, would have to sort of deliver all the certificates to the local participants. But that's the sort of thing that we're hoping the associate local coordinators can help with. The arrow that's just flashed up there went from sort of November, and that slid along to the right to sort of take us up to sort of March or so. So as I say, that'll stay open for sort of 3, 4 months, and we'll just gauge the response rate and then close that down. We'll keep you up to date with things, how that's going, at what point we're going to close it. Uh, but that's really the baseline surveys. The next thing will be the activity survey. There's not a huge amount to say about that yet, other than to say that will run in June. That, as you know, is that really intensive 1 week phase where we're going to need to collect data on every single anaesthetic. So that's where really there's a big job in terms of persuading everyone to fill out a form for every case. It'll all be done on Smart Survey, which is done on your phone. So it should be nice and quick. And times so far around about 3, 4 minutes per case. If you're doing regional anaesthesia, quicker if there's no regional anaesthesia involved. And again, as I say, that's really where the associate local coordinators will be able to do a really fantastic job, I'm sure, in persuading everyone to fill out the forms. So we'll give you more information about that in due course. The registry phase, this is going to be the big main component of the NAPs. There's a pack that's already on the NAP8 website and the college website. I've just updated that again today, just tinkered with that. So a new version of that will go on over the next couple of days. So that's the whole local coordinator document. We've got a slide set built, so that's going to come out to you soon. I know there's been a few people asking questions. We haven't really been sending it out because I don't really think that you need to be promoting it until about sort of January, February, so that we're not too far away from the actual start of the project. So that's all done, and that will come out to you over the next week or two. We'll be sending you out posters, flowcharts of all the things to keep the visibility of the project up in the department. And we'll also be sending you documents to link in with all the non-anaesthetic people that we were talking about, who are going to be some of the sort of avenues where we might pick up cases. So as I say, surgeons, physios, medical legal teams, all these people we mentioned a minute ago. So we'll have a spreadsheet of any person that we think might be important to contact. So you can go through that spreadsheet, see who of them is in your hospital. For example, our hospital doesn't have neurology or neurosurgery, so we won't have to contact them. And we'll have an email for you to send to all the clinical directors and all the relevant leads to get them engaged in the project, and we'll have material for them as well. So really, as I say, your job locally is to try and promote the project, not just amongst the anaesthetic department, but amongst all these non-anaesthetists as well that we were talking about before, the surgeons, the physios, pain teams, neurologists, etc. We've talked about this already, or I've showed you this already. I'm not going to go through every single complication, but if you click on the website, you'll see, as I've sort of mentioned already, the local coordinator document, and that local coordinator document has got all the different complications that we're looking for. And it feels like we're running about 22 naps in one, because there's clearly a lot of major complications of regional anaesthesia, albeit fortunately most of them are very rare. And I suppose the key message is, if you're in doubt, just report. There will be people you can contact. You're not allowed to contact the steering group because we are supposed to be behind a sort of firewall that we're all anonymous, but there's going to be independent moderators you can phone if you're not sure about what to report, and they'll take you through things. They're all being appointed at the minute. There'll be 3 or 4 of them who you'll be able to contact directly, and they'll be able to help you out. It's worth having a look at that document. So the QR code will take you there, that you can see in the bottom right, or you can click on the Royal College website. And I say, I'm not going to take you through every complication, but it's worth you going through that, and it's worth letting the department look through that as well when you're doing your departmental talk, just so they're aware of all the things that we're looking for. I think it's sort of obvious any major complication we want submitted, but it's worth just having a look at the inclusion and the exclusion criteria. You don't obviously have to commit them all to memory. They're all sitting on the document for people to look at, but it's going to be wrong route drug error, local anaesthetic toxicity. As I say, I'm just going to fire through these quickly. Pneumothorax, some of them are more straightforward than others. A pneumothorax is a pneumothorax, it's here in the pleural cavity. Cardiac arrest, following the definitions of NAP7. Infection, so again, this has to be major infection, not just inflammation or cellulitis at the site. Anaphylaxis, that will follow the NAP6 definitions. Visceral or other organs, that includes eyes, injury. Higher total complete spinals, respiratory failure, vertebral canal hematoma, vertebral canal abscess, infective meningitis, adhesive arachnoiditis, nerve injury after central neuraxial block, any other complication, all these rare things like posterior reversible encephalopathy syndrome, which get reported once in a blue moon. But we have to have a box for that in case anything else pops up. And then for peripheral nerve block complications, wrong site block, phrenic nerve palsy. So again, that's not someone who just needs a bit of oxygen overnight. That's someone who ends up with either a permanent phrenic nerve palsy, of which there are case reports, or someone who needs ventilated, which obviously would be very rare after a phrenic nerve palsy. Major hemorrhage, so again, not just a bruise, someone who needs surgery or interventional radiology or blood products after a peripheral nerve block hemorrhage, which again should be super rare. And the main one, peripheral nerve injury following peripheral nerve block. Any of those ones, like a peripheral nerve block injury, whether it's a peripheral nerve injury or a nerve injury after a central nerve axial block, there'll be an automatic email that will be sent to you all after you log the case. There'll be a follow-up email at 6 months. We can't change practice for NAP8, so we would expect these patients will be getting followed up anyway. And if they are, then we'll be looking for a report at 6 months to know if it's resolved or not. And as I say, at that point, it'll be kept in the database as a permanent nerve injury, and that's what we're looking to report. And then we've got the complications after general anaesthesia, so spinal cord injury and peripheral nerve injury after general anaesthesia. So to scoot through that, just scooting through all the complications, to say I wasn't going to take you through them individually. I think it's worth going to read the document. So this is a sort of timeline just to finish off where I think you need to sort of think about doing things over the next couple of months, if that's possible. So we're almost in December. So as I say, the individual survey is going to get launched next Monday. Over the next sort of few weeks, we'll be advertising the associate local coordinator scheme. So I think you'll have to think about trying to figure out an appointment process for that. When it gets to January and February, as I say, we're hoping to launch in March. So January, February is really going to be promoting the launch of the project, the department. So it might be worth booking a CPD or an M&M slot just now. We will give you the slides so that you can do a talk to the department. And we'll also be sending you all the template emails to start promoting the project amongst all the relevant specialty clinical directors and others. If it all goes to plan, we're still hoping to launch in March 2026. So during that whole 1 year, it's really about keeping the vigilance amongst you and the whole department in terms of promoting the project, making sure people are aware of these complications. We'll be sending you a monthly return form so that even if you have no complications, we'd like you to just let us know that you've had no complications, because that just lets us keep track of things. And as I say, the plan is to run the activity survey in the middle of the project, round about June 2026, before it gets to the holiday season. So that's where we're at. There's going to be more information on the website as that gets built up. We're going to start up a WhatsApp group as well. It won't be a sort of WhatsApp chat group. It'll just be a sort of distribution notification group so that we don't get bombarded with sort of 450 people pinging messages back and forth. So it'll really just be a sort of notification WhatsApp group. So you're welcome to join that once we get that started. At the end of it all, it's going to be 2028 before we actually get all these results in and disseminated. So at that point, you'll all be listed as collaborative authors, if that makes a difference to you for your help. And that's pretty much us. So I think it's pretty exciting. It's a huge project. It's been a huge amount of work so far. That was me last year in New York when I get told I was running the project. This is what ChatGPT says I'm going to look like at the end of the project. I'm sort of hoping not to be quite as bad as that, but that's where we're at. So, in summary, really, as I say, NAP8, we're looking at central nerve axial blocks, peripheral nerve blocks, and all the complications each for them, and perioperative peripheral nerve injury and spinal cord injury. It will be the biggest peripheral nerve data set in the world, so that's going to be pretty exciting. Baseline surveys are coming out next week, and really this sort of next month or so, I think from your point of view, is really just preparing for promotion of the whole project in the new year, and we'll be sort of feeding you lots of information to help with that. So that's been a sort of rapid whistle-stop tour through everything that's been done so far. So I suppose now we've got sort of 20 minutes, so it's more just to open the floor up for questions. I've not seen if there's any coming in on the chat or not. And we'll listen to your thoughts and any questions that you've got so far. So I'm going to try and stop sharing my screen if possible. Sometimes it doesn't work. See if we can just come out of that. There we go. That's off now. Right. So I can see question and answers 11. So I can't see anyone. I can just see these questions. So Nick, given the surveys are going live soon, when will posters and slide sets be available? So the posters and slide sets will all the slides are all done. As I say, we've not really been sort of having a big fanfare about the baseline surveys because they're arguably the least important part of the project. They're still hugely important because they're going to give us a huge amount of information. Uh, but we've not been advertising it much. So we're over the next couple of months, as I say, is the time to promote the main case registry. So the posters and the slide sets will all come to you over the next couple of weeks. And as I've said in the webinar, really, I think the time to start really pushing it is January, February. Ingrid, in Ireland, we aren't generally members of the RCOA. Is there a separate link for Irish colleagues to log in? Uh, to log into the Royal College website, I say it's hard because we can't sort of talk. I'm just trying to sort of talk because I can't sort of have a two-way conversation. But you don't need to be a member of the Royal College website to log in if that's what you're getting at. That's all open access, so you should be able to get into that okay. When it comes to the actual surveys, when you start the survey, there'll be a question at the top. Are you sort of answering the call? Are you answering from Ireland or are you answering from the UK? But if it's just in terms of the website, then you don't need to be a member to get into the website for all the local coordinator material. Is there a deadline for letting college know about local coordinators? Well, yes, in the terms of that we want to start in March. So ideally, we need everyone signed up by then, but it can be as late, it can be last minute. The sooner the better, because clearly we need to get Caldecott approval for every trust. But once we get started, we can't really then, you know, change it then. So really by March at the latest. Andrew, over a year, the pool of people available to help will evolve. So yeah, so that as you sort of allude to, it's unlikely that residents or locally employed doctors are necessarily going to be in the same place for 18 months. So I think you need to appoint at the start, and then it might well be, it's a bit of a fluid thing, we've never done this before, but it might well be that if you move from one hospital, you just keep your role and you go and help at the new hospital. Someone else might come to your hospital who's already been a local coordinator elsewhere. I think you just have to sort of keep your pool full, if that makes sense. So if someone leaves and no one else is coming in from a different hospital, then yes, you'll maybe have to appoint some more. Are there letters for recognising the role? We will definitely have to get all that, yes. So there'll be sort of thank you letters. All the local associate local coordinators as well will be listed as collaborators on the project as well when it comes to all the publications. Sorry, my sort of chat, it jumps up and down a bit, so that's why sometimes. So Daniel, limiting the associate local coordinators to stage 2 and stage 3 isn't practical outside of tertiary centres. That's a reasonable point. That was the decision that was taken by the steering group. I can take that back, but at the minute we've listed it as stage 2 and stage 3. Uh, I'll need to sort of speak to some people about that one. Daniel, can you message the NAP8 email address so that I've got your email? The problem is we're about to advertise soon, so if we sort of start changing it all now, it might be a little bit tricky, but I'll just take that back and have a quick chat before we sort of get the link, before we get the advertisement out. Lindsay, it looks like we might need to take some professional leave, non-clinical time during the June registry week. Any idea what the dates will be? In short, no. I'll try and get a date as soon as possible for you so that you've got time in advance, Lindsay. I would hope people wouldn't have to take too much time off for it, especially if you've got a sort of local coordinator network. But I can appreciate if you're wanting to be on site the whole time. Uh, so we'll try and get that date to you as soon as we can. So, but it's not been chosen yet. So the main thing at the minute we're trying to do is get the whole project up and running for March. As I say, it's taken ages to build the surveys up in Smart Survey for both the activity survey, which is actually pretty much ready to go, and the baseline surveys. And it's now just building up the case registry, which is getting done with a Newcastle Proms, in fact. So Billy Qureshi up in Newcastle runs Newcastle Proms. He's an anaesthetist, and he's got the job of building up the web tool for the case registry. So we have to get all the documents ready for that. So that's been the focus. But I'll have a chat about seeing if we can pick a June date soon, because there's probably no reason why we can't. Uh, I just need to make sure we actually get launched in March. Uh, Otherwise, we can't run that in June. Jonathan, June registrates for you, so yes, the same question yet, so that's a reasonable point. Are we looking at nerve injury secondary supraglottic airway insertion? So it's on the document. No, we're not looking for nerve injuries secondary to airway devices. That's one of the exclusion factors. Bruce, I can imagine patients who have a peripheral nerve injury persisting at 6 months would be pursuing medical legal action. So we can't contact, so it's a question, nothing should change. NAP8 can't change clinical practice. So you should be looking essentially through the notes. If someone presents with a nerve injury, I would argue that should mean they should be getting investigated and followed up as per standard local practice. So all that you would do at 6 months is to dial into the clinical portal, whatever system you've got, to see any letters and see what the investigations that have been done at that point and if the injury is still persisting. So you shouldn't really be phoning them directly on behalf of NAP8, if that makes sense, because that would be a slight change in clinical practice. We're not consenting all these patients to take part. So it's really just looking as a local coordinator or asking the anaesthetist who was involved, because they're perfectly entitled to be sort of following that patient up to see what stage things are at. There's a possibility at 6 months that we still won't have all the investigations. It takes a while sometimes for these things to get done, and we might not have all the information we need, but we can't keep NAP8 running for sort of a year or 18 months to sort of find all these answers. So the decision was been from chatting to Tom Quick, who's the peripheral nerve surgeon involved, that we categorise them as permanent at 6 months, because if you've got symptoms at 6 months, it's very unlikely that it's going to resolve completely. And that was the idea. But as I say, it's not to phone that patient directly on behalf of NAP8, because that's technically not what we're supposed to do. James, are we looking to report also expected nerve injuries, e.g. saphenous and ACL or medial cutaneous? No, so if that's a surgical nerve injury, then no. So if we had to collect every single surgical nerve injury, that would be a huge project. Some of the studies suggest, up to 10% of orthopedic operations would have a direct surgical nerve injury. So there will be difficulties in picking apart injuries that are related to blocks compared to injuries that are related to surgeons. And it'll be difficult for us because we, again, as you know, can't go dialing into the notes. We rely on you to give us all the relevant information. So there'll be a whole series of questions that we'll be asking that's getting built up just now in the case registry to try and guide you through the case. And if you think it's pretty much guaranteed to be a surgical nerve injury, then we don't want to know about it. If there's any dubiety, then report it, and then we'll look at the data. And we'll probably end up doing something in terms of reporting it along the lines of, of the 300, whatever it is, nerve injuries, 100 are definitely due to regional anaesthesia, 100 are definitely not, and there'll be 100 in the middle where we can't say for sure, and we'll have to report it in that sort of way. But if you know it's definitely due to the surgery, then don't report it, because that's not what we're looking for. Ching Ling, sorry, I can see a few questions along the same. Can we clarify? All cases where surgeons, other operators perform blocks autonomously, where the patient is not normally under care. So if they've not been under the care of an anaesthetist, then we don't want to know about it, because it has to be just where there's been anaesthetic involvement. We can't really get involved in blocks done by surgeons or emergency physicians. Uh, Anonymous, I'm sure this has been considered already. So will NAP8 investigate differences in nerve injury for blocks performed while awake versus under GA? So yes, whether we get enough data to answer that question, I don't know, but we will be asking in the activity survey for each block a limited number of questions, and that will include awake versus asleep. We'll look at that, we'll look at needle size, we'll look at ultrasound, yes or no, and even though I've been looking at it for the last year, I can't quite remember the other. It'll be the grade of anaesthetist as well. And I think those are the main questions we're asking the activity survey related to the actual block. When we get into the case registry, if there's a nerve injury, we'll be asking all sorts of all sorts of things about the nerve block, far more detail, but we can't ask too much detail in the activity survey, otherwise it would take people far too long to fill it out. So if we get enough cases, then yes, we might be able to tell the difference. That case series I showed you, or not the case series, the narrative review with 92 studies. So as I say, they had 107,000 patients, and with that number of patients, and we'll have more, with that number of patients, they started to see in the first a in the first couple of weeks, there was a difference between ultrasound and non-ultrasound in terms of the rate of nerve injury. But the reason they saw that difference because they were looking at nerve injuries within 2 to 4 weeks as well. And there's far more of them, as you know, because we sort of have that exponential curve where you get a lot of injuries at the start and then far less later on. So whether we'll see a difference, I don't know, because we'll have far less uh, of the sort of nerve injuries at 6 months. But we'll certainly be looking at it. Dr. Bacta, nerve injury cases related to central neuraxial blocks and peripheral nerve blocks will possibly be reported to anesthesiologists. But how can we collect data on non-regional anesthesia related nerve or spinal cord injury, which are not directly related to anesthesia? Well, that question just vanished off my thing, so don't know what's happened. Sorry, I saw someone was typing, so
Apologies,
maybe
I answered Alan,
sounds like
sorry.
Sophia's answered your question, so hopefully that'll uh, give you an answer. Anonymous, I'm sure this has been considered already, so apologies if it has. Will NAP8 investigate differences in nerve injury for blocks? Oh, I think we've just answered that. Are we including continuous nerve block related equipment like catheter dislodgement? So we're not picking apart manufacturers, and catheter dislodgement isn't something we're looking for. That's far too uh, it's far too non-major is the term I'm looking for. It's not a major complication, so we're not interested in that, I'm afraid. Much as it's interesting, but not for NAP8. So Kieran, my hospital is exclusively for obstetric anaesthesia, and complications would be referred to the neurocentre at the Walton, Liverpool. So I'm sure if the neurocentre has anaesthetic people, I'm presuming a neurocentre, if it's neurosurgery, surgery must have anaesthetists involved as well. So yes, so because we're aware there's some hospitals that are just exclusive obstetric hospitals, so there's questions that are suitable just for obstetric anaesthesia hospitals. If there's a complication and you became aware of it, what I would suggest, because this will be relevant to independent sector complications as well, is if you do an obstetric case and you're aware of it, I would speak to your colleagues at the neurocentre as well, just because we don't want it double reported, if that makes sense. Uh, and that's relevant as well for patients who have a complication in the independent sector and maybe then present in the NHS. There'll be a box at the start of the case registry to say where did this complication occur, if it happened in the independent sector or if it happened in the NHS, but we can't collect data on what hospital it appeared at, so we're not allowed to do that because it all has to be anonymous. So we won't be able to ask, did this happen in an obstetric hospital alone in in your place, obviously, and then did it present in Liverpool? So there'll need to be a wee bit of double checking, I'm afraid, at your end on that point. I'm not sure if we can do any more about that. Sorry if already answered. Do we collect tap blocks, pudendal blocks? Yeah, so if by surgeons, so if there's an anaesthetist there, then yes. And yes for local anaesthetic into port sites. We want local anaesthetic infiltration. If there's an anaesthetist present, then will there be a box to tick for that? And for the surgical blocks. Annie, from what I understand, we do not contact patients directly at any point. It should be through the primary clinician and the follow-up. Yeah, so that's correct. It's all got to be done just in terms of routine follow-up. We're not consenting patients to take part, and it's all anonymous, so you just have to follow them up as per standard processes. That's Daniel's email. Thank you, Daniel. I'm just going to Selnick. Amit, I can see at my place there's just one local coordinator. Do I need another to help? I don't know. It's really it's up to you to decide on the size of your hospital. So as I say, the Royal, we've got 30 ORs plus a separate standalone day surgery hospital, and our obstetric theatres are a different section as well. So we've sort of decided to have three for 30 ORs plus a day surgery centre. So it's really up to you how many people you think. You've already seen people allude to the fact that over June, if it's a week, I know people sometimes they're split site working, so it might well be you think you need a second person. It's really entirely up to you. There's no magic number. You're welcome to have more than one if you want. Alan, any suggestions for how to encourage surgical colleagues to let local coordinators know, which don't relate to regional anaesthesia? Uh, well, we're sort of not really, we're not interested in the ones that are due to direct surgical injury because that's nothing to do with us. If it's positioning related injuries, then hopefully that sort of thing I think will come to us. I know what you're saying about tourniquets. I think we just have to promote amongst all our surgical colleagues, orthopaedic surgeons in particular. We've got Tom Quick, who's an orthopaedic surgeon in our steering group, and he's going to be preparing a little sort of video. And there's work about to get published in some of the orthopaedic journals, or I can't remember, the Journal of Trauma and Orthopediology. I think it's like our college bulletin essentially. It's just a short article promoting the project. And there's going to be messages coming out from the BOA president and things as well. So we'll be trying to sort of promote, there's Rosie Hogg and others that are trying to promote it amongst all the non-anaesthetists as well. So, and I think it's really just our job and your job as local coordinators to keep the sort of buzz about the project going and try to encourage all the surgical colleagues to that we're running this project and to feedback any complications that come in. Uh, Venkat, sorry, I'm just firing through all these questions as quick as I can. So, can trainees cross over hospitals? Yeah, so I think that's fair enough. We're expecting most residents won't be in the same hospital over the same 18 months. So I think they can slot into another hospital, and it might well be that someone slots into your hospitals. Tara, just in terms of booking annual leave, though, we would not need to have all the local coordinators on annual leave in the June. Yeah, we don't want to have that. That wouldn't be ideal. Uh, so, yep, I'm going to try and get the date for that sorted. That's been a few people have obviously mentioned that, so I'm sorry we haven't thought of that to get a date for that sorted. Kazi, I have just got on board as a project. I've notified my CMO, but it has not been updated in the RCO. Yeah, so we're just building that all up just now. As I say, one of Laura's been off, so we're just catching up with the website. So I am conscious my hospitals are not on it either, so we're just getting that built up over the next couple of weeks. Federica, would it be possible to have a summary of the questions and answers? Hopefully, this has all been recorded, but maybe that's a good idea. We could try and type out all these questions and put in the responses as well. So in terms of following up patients, you shouldn't be following up patients. If you don't follow up patients, then don't follow them up just because of NAP8. That's a change in clinical practice. We can't do that. So as I say, I'm conscious that we might get criticised for underreporting, but I do hope that the big major nerve injuries will make it back into our system. We're going to be running a separate project. I didn't want to give you too much information, but we're going to be running a separate snap on immediate follow-up of patients. They'll all be consented, they'll all get text, but that's completely separate to NAP8. So for NAP8, we can't follow up patients any different than your standard practice. We just have to wait for them to get fed back into the system. And that's why we have to really sort of push all the surgeons for when these patients come back to clinic or physiotherapy, if there's any issues, to come and let us know. Julian, we do lots of hand surgery for trauma patients, traumatic nerve injuries. They've had an axillary block. How do we differentiate? So, yep, the form will take you through that. As I say, the form will be asking for the location of the nerve injury. From talking to Tom Quick, who's the nerve surgery expert, we're not going to be asking you to say this is in C5, C6. We're just going to ask you for the distribution of where the injury is in terms of sensory motor deficits, and then we'll ask for information about the operation and potentially the injury as well from the traumatic nerve injury. And then it will be up to us and you as well locally to sort of give us your opinion, what you think it is, but we'll then look at the data as well and on the case registry form and try and categorize it as well, whether we think it's due to the block or not. And as I said before, some of them I don't think we will be able to tell, and we'll have to report it as that sort of indeterminate essentially. Richard, so to clarify, we're including surgical nerve injuries due to positioning and stretch, but not the knife, yeah. So vascular and ischemic neurological injuries, yes, that will get included as well. So anything, but it's not due to the knife, essentially. Maybe that would have been a better way to explain it. We've been sort of saying not directly due to the surgery, surgical injury, but it depends how you define surgery, because like you say, all these things, vascular, ischemic neurological injury can happen during the procedure. Jane, do we need to check if any patients have opted out of having their data? I don't know how we would do that. Uh, it's a good question. I'll need to speak to the team. We're getting Caldecott approval, but if patients have opted out, uh, Christine's got her hand up. Enlighten me.
So I think the short answer is no. You would have to screen for patients on the National Data opt-out list if NAP8 had applied to the confidentiality advisory group to collect patient identifiable information without their consent, but that is not what is happening in NAP8. We are not collecting confidential patient information. So it falls outside the remit of CAG and therefore also falls outside of the remit of the National Data opt-out. So no, you do not have to screen these patients before adding them.
Yeah, that makes sense actually, and that was good. I actually got to drink a bit of iron brew there to keep me going for the last 5 minutes to scooting through all these questions. Uh, Isan, what about the patients who present with chronic post-surgical pain? Uh, if it's due to a nerve injury, due to regional anaesthesia, or the other causes of nerve injury we've discussed, then yes. If it's just post-surgical pain, which I get what you're saying is possibly due to nerve injury, but not always, then it's not going to be included. But if it's due to a nerve injury, then yes, and we'll be asking about pain, and as part of the nerve injury in the case registry document, that's one of the things. Pradipta, do we need to look into local anaesthesia infiltration by surgeon or nerve catheters inserted by the surgeon? Yes, is the short answer to that. If it's been put in when we've been present, then yes, if there's a complication, we want to know about it. Is there a possibility for sites to have more than one local coordinator? So that was the same as Amit's question. Then yes, as I say, we've got three in our site because we've got two separate hospitals and we're a big hospital. So it's up to you and your clinical directors to decide how many local coordinators you think is appropriate. There's no magic. We've been asked before about how much sort of SPA time can a local coordinator claim for. And the college stance really is that obviously it's difficult because there's so many different hospitals and different sizes. And even though we've got a rough idea of the work, we can't give you an exact number. So if you think you need more than one, then that's not a problem. PIEB for labour epidurals, high volume, delayed wear off, one-sided weakness, which resolves. That I wouldn't put down as a major complication. It's not in our list. So again, it's worth just having a look at the QR code and go on to the NAP8 website and have a look at all the big list of complications, but that's not one of them. Do we need to document any neuropathic symptoms in diabetic, I presume, patients as a baseline? You shouldn't be doing anything different than what is your standard practice. So, in patients who've already got pre-existing neuropathy, who then present post-operatively with a new nerve injury, will be difficult to pick apart, but you shouldn't be documenting anything different for your normal anaesthetics. If at 6 months' time the patient is being followed up, the next appointment is a few months away and we don't know whether it's resolved, then yep, you have to just wait for the appointment to happen. We'll have to put that down as a I don't know essentially. As I said before, we can't keep this open for forever. It's already been kept open longer than a normal NAP because we need to give, as I say, that patient who might present on day 365 6 months for the injury to resolve. So and it's difficult because they might present on day 365, but the operation was 2 months before, but we're not allowed to sort of put in dates. So we have to just make sure it stays open for 6 months from the time they get put into the database because as I say, we can't ask about dates because that then starts to breach the whole I can't say it, anonymity. I give up. It's been too much chatting. Severe PDPH requiring blood patches, no unless they end up with some sort of weird and wonderful cranial nerve injury, which can happen after severe PDPHs. But if it's and just inverted commas, because I know that's pretty severe for a patient, but if it's just that, no, doesn't meet the criteria. Zoe, how many associate local coordinators? We are a large hospital. As I said in this sort of chat, there's no magic number. I was sort of suggesting maybe sort of matching up the same numbers as you've got of local coordinators, but if you think you need five, then uh, you know, so be it. I think that's probably reasonable. Uh, lots of neck of femur patients come in with a fasciolacca block in A&E and us provide a block during surgery if there's a nerve injury. Yep, we might not be able to differentiate that, so that's a fair question. That'll be all stuff that has to get logged in the case registry form, but it might be impossible to differentiate. Ahmad, the standard practice is to follow up patients who receive certain blocks by a phone call. So that's great. If you're following patients up already, you might well pick up patients. So yes, please just do whatever you do as your standard follow-up. We won't, most hospitals aren't going to have a way for following up in surgical clinics. That's why the whole project is really trying to promote it amongst all your surgical colleagues to feed these cases back to us. As I say, I do think, maybe I'm being naive, but I do think the big cases will get fed back to us. So there's technically a minute to go, but Christine, there's 5 questions. I don't know if we can just keep going or if hopefully it won't shut down. But Ed, the process of selecting the associate trainee, should it be through an interview process on the RC? So there's a scoring system. We think it's fair and transparent, hopefully, because we've got that document there and it's based on a lot of criteria. It's gone through several people on the panel. So I think we should be sharing with them the scoring system and the essential and desirable criteria. And it's up to you whether you just want to score everyone. If you want to interview people, then that's fair. I wasn't sure if that would be a lot of work for you all, so I thought it might be simpler just to score it and then uh, do it on that. But if you've only got a couple of people and it's all very close, then feel free to interview. But if you've got 20 applicants, then it could be quite a big process. So you might want to narrow it down to the final 4 or 5 and interview for 2 or 3 positions, for example, and really leaving it up to all you to decide. Ash, is it worth asking if the Royal College of Surgeons to publicise? Yes, so the RCS are one of the partners, so we're working on sort of promoting it amongst all these organisations. Kieran, you work at obstetrics and gynae mainly. Some of my patients might have had a central axis block but may develop perineal nerve injury due to positioning. Uh, yes, that would get reported because that's a nerve injury that's not due to a direct knife surgical injury. So we'd want to know about that. And again, we would try and pick it apart if it's due to the central axial block or if it's due to positioning. Kieran, or peripheral nerve injury due to lithotomy. Yes, that should get reported. Pradipta, how can we follow up patients if we don't record their personal information? You don't have to follow them up. That's the whole point. We can't be following patients up because we're not consenting them to take part. So you're relying on patients to come back into the system and then you get involved at that stage. So if a complication happens during their time in hospital, if they have a cardiac arrest or same as any other NAP, if they have an anaphylaxis, if they have a pneumothorax, then you will enter all their details anonymously. If they come back 3 months later with a peripheral nerve injury, then great. But once they've gone from the hospital, you can't follow them up. We're relying on them coming back essentially with a peripheral nerve injury and being fed back in by the surgeons or a physiotherapist, as I say, or a neurology team. Uh, that's it. I feel like Martin Lewis from that Money show, the money saving expert, whatever is it? Except he probably answers questions a lot better than me. So that's us. We're just 2 minutes over. I think we will try and get all the questions maybe put into a word form. That was a good idea, and I'll promise I'll try and get some dates for June. I think that should be fine. I'd be very surprised if we can't launch by June. So we just needed it to be during the case registry. So hopefully, if we do get launched in March, then we should be able to definitely run the activity survey in June. So we'll try and pick a date for that soon so that you can all plan your leave. Are there any specific questions, last one, in the reporting form to prevent the duplication of data? That's something we need to think about, as I sort of touched upon, in terms of if a patient presents to the NHS, but they've been done in the independent sector. But there's not a sort of set question at the minute that is a sort of very smart, cunning question to prevent duplication. So we're sort of relying on you all to sort of communicate, if you've had a patient in your hospital that a local coordinator and an anaesthetist don't put in the same patient. Uh, so hopefully you as a local coordinator can help control that process locally in your hospital. Uh, okay. Yes, Madan, we'll try and sort of do all that. That's a good point. So, right, I better let you all get away, but just to reiterate again, thank you all for joining us. Thank you all for helping us out. as I say, it's a huge amount of work behind the scenes trying to get it all up and running. So apologies if you're still not, got your name on the website or if you've not had the slides set yet. That it's all coming. Things are just taking a bit of time. But everyone's working hard, but we can't do it without you all as well. So just thank you so much for all taking part. As I say, I do think it's an exciting project, much as sometimes it's killing me. But like I think if we can sort of pull it off, it's going to be pretty cool. And I say we can't do it all without you. So uh, please, any hassles, get in touch either me directly or use that NAP8 website email. And as I say, we'll get stuff out to you and start building up all the information over the next couple of weeks so that we're all set to start big promo in the new year. Okay.